हाँ कर दो रहा है शुरू करो should I start okay all right, so now we will delve into the how to address the problem. We talked about what the problem is. We talked about where we stand from an understanding point of view, and what are the gaps, and what's going on all over the world. What is happening from an understanding point of view. Now we'll talk about how we can address it, and what's the future like for this growing, some people call it even global epidemic, and that's what it exactly is. All right, so this is the second part. I'll talk about complications, the treatment options. The primarily this the chunk and the bulk of this talk is about treatment options. We will address some aspects of cost effectiveness, and because this is Pakistan, we have to talk about stuff what we can implement from tomorrow, and what we can do for our patients in a democratized manner, and what is the future like, and also from a national public policy perspective, what are the barriers, and how we can, being a clinician, being an academic, from an academic environment, how we can play our part. Okay. All right. So, as our esteemed colleague was just mentioning, that the number one cause of reduced vision is refractive error. Everybody knows that from day one. And even there are places, not just in the world, even in Pakistan, where people just go their whole life and they never realize what a good vision is, what a 6x vision is, because they never thought. Even right now, even in academic circles and even in educated circles, there are many people who don't understand this concept of vision screening. We don't have this concept of vision screening on a national level. It is not mandatory in government public schools for every child to have vision screening. And I'm talking vision screening. I'm not talking a comprehensive eye exam. I'm not even talking about follow-ups. I'm just talking about a vision screening, which is the easiest thing to do. And one doesn't even have to be a qualified technician to carry that out. So that's one thing. There are these complications about Retina. Everybody knows that. Irfan told me before the talk, we eat our residents' brains out, with all the complications, and we let them prepare for, we can have a whole detailed talk about how to address these complications. I would mention a couple of things here. These complications do become really important when we're dealing with the higher end of myopes, especially the serious ones, the ones which can affect somebody's vision forever. Stuff like myopia, choroidal neovascularization, stuff like advanced myopic maculopathy. Patients with advanced myopic maculopathy, and a lot of times patients with myopic CNV, they go unchecked. They come to you, you see the fibrotic membrane already there, and there's nothing we can do. But from a clinician's point of view, we know we can easily treat myopic CNV. Usually takes only 1 or 2 injections. I've hardly treated anybody's myopic CNV with the third injection. So that's, we need to tell that to our patients, especially the ones who have high myopia. There's a caveat here. Because I was over there, the incidence of myopia in Singapore is about 80%. We would see a lot of myopia. Sometimes, even with patients with moderate myopia, -4, -3.5, even they would develop myopic CNV. So it is not just something that you would be looking out for in somebody with a refractive error of -16 or somebody with a refractive error of -18. Anybody can develop that, especially the moderate and most definitely, the high myopes. There is a risk for that. They say 10% of high myopes can have the serious complications, but that's that. Okay. The other thing I would mention here is the staphyloma. People think that they can pick up staphyloma clinically. That's not the case. Even the most trained eye cannot pick up staphyloma sometimes. Sometimes it's not even in the arcades. Sometimes it's away from the arcades. We need to look at the borders to really be sure that this is a staphyloma. Sometimes B scan helps, but then one needs a dynamic B scan. I've noticed over here in Pakistan, most eye doctors are not doing B scans themselves. When we do dynamic B scan, somebody who knows what he or she is looking for, they can pick it up. And the most certain way of picking it up is, really 3D MRI, as I mentioned in the previous talk. Okay, we can have a whole talk about actually these complications. Anyways, we'll just move on. Okay, so this is the traditional understanding of myopia. That's what everybody knows. That's what every eye doctor does day in, day out. Patient comes, they're given single vision glasses. Patient comes, they're prescribed soft contact lenses. And if somebody really hates glasses, somebody cannot wear contacts, they're given these options. Oh, we can do refractive surgery. There's an upper cutoff, there's a seating for that. We look at your corneal thickness, stuff like that. People have started doing phakic columnar lensing IOLs. It's been happening for some time. A lot of authorities consider it very safe, especially for the ones which are very high myo, usually more than -8 or -10 diopters. And there's always options of clear lens extraction where you can take out the natural lens and just put in a monofocal or multifocal implant. So this is the routine stuff. Okay. Now, this is what our talk is about. We will talk about the environmental options. Patient comes to us, what we can do to stop the onset or what we can do to stop the progression. There is robust evidence that time outdoors, 14 hours a week, you average it out 2 hours per day, it is beneficial. It stops the onset. There is no money involved. In a country like Pakistan, we don't have the problem of space. This is not Hong Kong and Singapore where people have space issues. Everybody can go out and everybody can have an easy morning walk. Everybody can go out and everybody can have an easy stroll in their evening times. It's easy, it's cheap, it does not cost any money. And from a basic molecular understanding point of view, there are so many benefits. There are countries, Scandinavian countries, they don't have sunlight exposure the way we do. So they really covet it. Some of the lowest prevalence of myopia right now all over the world is in Scandinavian countries. And those are developed countries. We usually tend to say that myopia's prevalence has been going on all over the world. It's not really like that. Countries where there is good enough sunlight exposure and it's part of their culture, countries like Australia, countries like Scandinavian countries, the myopia prevalence is really low. It's less than even 10%. And so we need to talk. This is a public health topic. This is a public health perspective. I can stand here and just talk about this for 5 minutes and then I will just move on and we will be done with this talk. We are all clinicians. We can just say that to our patients, spend 1-2 minutes. How we can implement it on a national level, how we can do that, it's really hard. And our esteemed colleague, as she was mentioning, how we will implement that to our pediatric population, to the kids, millions of kids who are in madrasa environment, millions of kids who are in a government education setup and environment. How we can do it to those, how we can make it a part of national policy. Taiwan made it a national policy, 2 hours per day. They made it so much that 1 hour is being done in the schools. So you have a school of 7 hours, 3-hour study, 1 hour outdoors, 3-hour study. And it's a tropical country, it's a hot environment over there. So that's something that we really need to talk about. Okay, does the time outdoors help us and prevent with progression? The evidence right now is not certain. That's what we need to tell our patients, that right now the evidence suggests that it does help with the onset, doesn't really do so much with the progression, but it's a healthy thing. We might have more evidence in the future where we find out that, oh, okay, fine, we were wrong about that, it helps even with the progression. Okay, we have enough evidence right now, and it doesn't cost anybody any money. So with this caveat, from a clinical perspective, we can tell our patients that time outdoors should be done. All right. Second thing is about the, we will talk about the, atropine and benzapine. We'll talk about what the lutein, the evidence for that is not really robust. We'll talk about the optical options, what they are, all the defocus and the defocus spectacles and defocus contacts and orthokeratology. We'll talk about that. And then at the end, we'll briefly discuss these very new techniques of red light therapy and procedural reinforcement surgeries to address myopia. All right. So I hate busy slides, but this is one of the pioneer slides. I'll mention the pioneer slides: Clear, Comet, Atom 1, Atom 2, and LAMP. These are the groundbreaking stuff that helped us lay down the foundation for myopia to move forward. This is an American study, very robustly done. It's not an intervention study. It's like a longitudinal study that helped us understand where people stand from a myopic perspective. And they have their own yeah, they had their own cutoff of what myopia is. This was the patient population. These were the kids they totally found, and this was the distribution. So ethnicity plays a part. It's found more in Asians, it's found more in browns compared to the whites. Whites have the lowest prevalence of myopia. Okay, this is the second study. All right. So first they did was the comet, and then they just removed the intervention and just moved on and longitudinally followed those patients. This is the myopic progression on average. I did not mention about progression. What is the annual progression of myopia on a global level without intervention? It's about half a diopter. Okay, obviously it varies. When somebody has very high myo, when somebody is very young, this is not the case. Everybody would just vouch for that. There are clinicians in this room. There are kids who they progress this much in 3 months. And we have kids where this progression is way more than that. But there is increasing global prevalence of myopia. But this progression rate is not increasing. The prevalence is increasing, the annual progression rate is not increasing. We should be very much mindful and clear about that. So that's just one thing that I want to mention here. Okay, so this was the average myopia that they found in their children. All right, these are the results of the study. They gave them, so when the evidence came that peripheral defocus helps with the peripheral defocus plays a part. In a myopic eye, when the idea changed from a foveocentric to a retinocentric, the whole retina plays its part, and the signals at a basic molecular level from the periphery of the retina. A myopic eye has hyperopic defocus in the periphery. It's basic physiology. When that hyperopic signal goes to the eye thinks, oh, I'm hyperope. Okay, let's grow more so that I can address the hyperopia. So the eye keeps on growing. So they came up with this hypothesis that if we switch this peripheral hyperopic defocus to a myopic defocus, and we tell the eye, hey, we are not hyperopic, we're fine. So then the stop signal is taken into account and the eye stops growing. So they gave those kids progressively add lenses which are commercially available, and then they gave them this. So what they found, okay, year one there was some effect. This effect tend to plateau in year 2 and year 3. That's the case with most of the therapies right now. We'll talk about atropine, we'll talk about that, and we find this. There is some effect in the first year. Then it tends to plateau. The effect does not move forward. So these are the studies. We'll talk about Adam 2, Adam and Adam 2. This was done in Singapore. This was followed by LAM. These two are atropine studies. I've talked about Comet, and this is a blink study. This is a study where they gave them bifocal lenses. They did not give them multifocal lenses. In Comet study, they were given multifocal progressive AT lenses. In Blink, they were just given bifocal lenses. Okay. All right. This is the mechanism that they postulate. This is the mechanism of a defocus lens or contact lens or spectacle. The central vision, the central part serves as a single vision lens. So it gets the patient its 6/6, the central vision that they require. And then we have these different formulations and different combinations. Some people have lensless, some people have ads segments. There's so much. There's so many. Every other day, something is being approved and something is coming forward in one way or the other. Essentially, what they all do is they change this signal to the periphery of the retina into a myopic defocus signal. There are some new designs which even change the contrast. They don't really change the refractive power, they change the contrast through the peripheral design. And I'm not going to mention those because there's no evidence for that. It's only for initial clinical trials. There are even softwares now where kids can just use their screens and the periphery of the whole screen acts as a defocus segment. So a child is learning something, playing a video game, doing whatever, chatting or something. So this part acts as a central vision, and the periphery of the whole screen acts as a, and it's going to be dished out very soon. Some Israeli and American researchers are industry partners in that. Okay. So this was the design behind Blink study. Now it's very blurry. I apologize for that. So they gave them three different types of contact lenses. This is a single vision lens. This is a lens with medium ad, and this is a lens with high ad. Single vision lens and medium lens. There was no benefit. There was no decrease in the progression of the myopia. It was only in the one with a very high ad segment that they found the statistically significant decrease in the progression of the myopia. And eventually the researchers concluded that it is statistically significant. It's only 0.2 diopters. It is not clinically significant. This is the same thing. Year 1, year 2, year 3. And over here they have the powers. Over here you see the ones with the high ad, they are the ones who did not really progress. The ones with the high ad. But the ones with intermediate ad, which is the blue ones, or the ones which we just had regular routine single vision lenses, they all kept on progressing. They all kept on progressing. Okay. Now, this was the landmark study which my senior colleagues over there did that. It was way before I went over there. And the evidence for atropine goes way really back, all the way to even 1960s. And there was evidence that, but back then glaucoma, myopia was not really a huge problem. But the evidence goes all the way back to 1960s, where there's some researchers found that, there is some role of atropine. Back then, they did not play with the concentration. They only gave, this was 1960s, I'm talking, like half a century, more than half a century ago. Anyways, so in Adam 1, what they did was, this is more than a decade ago, they gave patients atropine. The concentration was really high. They gave them 1%. Okay, and so they gave them and then they followed them. So these are the placebo patients. These are the patients who did not get anything, right? And because they did not get anything, they kept on progressing. The myopia is increasing. They did not get anything, the myopia is progressing. They did not get anything, the myopia is progressing. This was followed up for 5 years, okay? And so what they did was, at the end of the study, they concluded that, okay, fine, we'll give atropine 1%, it stops myopia progression by 80%, but there's so many visual symptoms. The patients cannot accommodate. They have visual problems. So let's just cut it down. And let's see if we can come up with something that it addresses this progression, but at the same time makes the patient stay functional, makes the kid stay functional. So that's exactly what they did. At the conclusion of the study, they said, okay, fine, we will just switch over now, patients. We will not have kids who will never be treated. And they did that with the lamp, actually. So this is what they did. They switched to 0.01%, they switched to 0.1%, 0.5%. The lower the concentration, the minimal the response, right? But they still found response even with 0.01%. It is a modest response, but it is something that can be offered to the kids. Rebound effect was found. What does that mean? When the treatment was stopped, the ones who were given treatment, they just match up with the ones with the controls. So that is clinically significant. We start our kids on atropine and the kid never comes back and they stop the treatment on their own. What are we going to do? We cannot follow up that patient. So what was the point of our treatment if the kid was eventually going to stop? And based on the data that I previously showed, myopia is a progressive disease through first decade of life and definitely even through second decade of life. Most of the times, if not all the times. So we need to have this serious chair talk, table talk with our patients before we put them on this. We need to tell them, look, it works, but you cannot stop it. And there's a very good chance that you might be on it for a good 10, 15 years. It is a safe thing, but it is your. So these are the studies, we went through that. All right, let's talk about the optical options. Last decade, they came up with plastic lenses. Everybody knows that rigid gas permeable lenses are basically plastic lenses. They came up with these lenses, and what this orthokit technique, what it does is, a kid puts in a plastic lens, which is like a rigid gas permeable lens that we usually give to our patients with very high aesthetic. The kid puts it in, goes to the sleep, wakes up the next day, takes it out, goes and does his or her whole day activities without anything. The kid is sick throughout the day. Why? Because of the central corneal flattening of putting in the lens for about good 8 hours during their sleep. Up till now, orthokeratology is really found to have robust, significant decrease in progression of myopia. It's about 50 to 60%. It is very expensive. Even in Singapore, only the rich ones could afford it. It costs about thousands of dollars. So in our Pakistani setting, right now, I tried finding people who do that. Nobody does that. I heard somebody in Peshawar is doing that. They don't do that. I heard somebody in Karachi is doing that. They don't do that. They can bring it in, maybe, but only for a specific segment of our society. There is no democratized version of orthokeratology available anywhere right now in the world. So that's that. The second thing is the defocus spectacles or the contact lens version of it. And there are many options available right now. The famous ones are by Hoya and Zeiss and many other standardized brands. Usually, we will talk about this, these defocus spectacles, they're very comfortable from a patient's perspective. Orthokeratology, it's not really comfortable. It is expensive in the way that the refraction keeps on changing, and the patient has to go and see that optometrist every 3 months or that optician every 6 months. And when the prescription changes, they order a new pair. It's more money out of the pocket. That's not the case with defocus ones. The refraction is the same. If there is no progression, it stays the same, and the patient discontinues. Right now, even in Pakistan, even in Lahore, we have a couple of people who are offering that. It is not cheap. It is not cheap. It costs about 50, 60,000. But there are cheaper versions of it. It costs about, from Italy and Europe, but it is still not cheap. Okay. This is just a schematic of, I briefly mentioned that there are many ways of this. Some people call it DIM, some people call it tongs. Those are just names. The point is, the technology is the same. I'll answer.
Assalamu alaikum. To prepare 10 ml of 0.01% atropine sulfate ophthalmic solution from atropine sulfate injection. So it is 1 milligram per ml if it is 0.1%. As it is not FDA approved, So not available at pharmaceutical from a pharmaceutical company. That's why we have to prepare in our operation theaters under laminar blood flow. First of all, it required a clean aseptic area, that is operation theater. And then after proper taking aseptic measures, try to maintain all aseptic measures, like there should be a proper trolley. We can make the atropine 0.01%, eye drops from atropine sulfate 1%, or we can use the atropine injection. We can dilute the atropine eye drops into available normal saline, or we can dilute in balanced salt solution, or we can use the artificial tears. We have taken 10 ml normal saline solution. We are preparing it from atropine sulfate injection. We can use 0.9% normal saline, or we can use the balanced salt solution. We have taken an empty sterilized bottle. We can also prepare the drops with the atropine eye drops bottle. This is 1%. And we are using the artificial tears for the dilution purposes. We have taken 0.1 ml atropine eye drops and dilute in the 10 ml artificial tears bottle. After preparation, we apply a proper sticker and we mention the manufacturing date and expiry date. Almost it remains for 1 month in 2 to 8 degrees centigrade temperature. We can use for 30 days. Thank you. ये एक हमने एक बॉटल है जो कि हमने स्टरलाइज एम्प्टी बॉटल थी जिसको हमने स्टरलाइज करके और इसमें हमने एट्रोपिन आई ड्रॉप्स प्रिपेयर किए और इसमें हमने प्रॉपर स्टिकर अप्लाई किया जिसमें हम इसकी मैन्युफैक्चरिंग डेट मेंशन करते हैं, टेम्परेचर मेंशन करते हैं और ऑलमोस्ट ये 30 डेज तक रहता है। और इसी तरह हम एक आर्टिफिशियल टेयर्स की बॉटल में भी इसको प्रिपेयर कर सकते हैं और इसके लिए हम एट्रोपिन आई ड्रॉप्स भी यूज कर सकते हैं और एट्रोपिन इंजेक्शन भी यूज किया जा सकता है। डिफरेंट कंसंट्रेशन में अकॉर्डिंग टू योर स्टडी आप जो है इसकी कंसंट्रेशन डिसाइड कर सकते हैं कि आपने 1% यूज करना है, आपने 0.05% यूज करना है, 0.025% यूज करना है या 0.01% यूज करना है, उसके अकॉर्डिंगली आप।
Okay. We'll take questions and answers at the end of this talk. No, it's only HS, only at night, only at night. All right, so we don't know the exact mechanisms how RLRL works, but these are the parameters. There, currently two platforms that they're dishing out this. It's done twice a day, 5 times a week, 3 minutes each time. It's an average size pupil in mesopic conditions. This is the intensity. 650 nanometer is the frequency, and the power and the wattage is 0.29. Dr. Irfan will go through. We have our prototype where we can control these parameters. He wants to make a lot of money, but that's the idea, so that we can dish it out to our patients in a very affordable manner. Because currently this is very expensive. In Australia, what we would do is in Jinnah Hospital, we would just rent out this device to our patients, and we would just charge them $1,000 for the whole year. In Singapore, some people would just buy it, and others would just rent it out because it's too expensive. So you take over from here.
Can you hear me, everyone? Okay, just about the RLRL. It's just a prototype. We just try to, it's just a humble or initial effort just to show that what we studied or what we saw on different international platforms, that there is the red light or RLRL is working for to stop the progression of myopia. So what we did that we got through all the data, we established a small device for that. So this device has different LEDs of like infrared or red or yellow light. According to certain data, the red light is working for progression of myopia. Infrared and yellow and red light are working for to stop the progression of dry AMD. So in this device, it has different LEDs in it, and we have started enlisting our patients in Jinnah Hospital, and it has certain LEDs with specific wavelength. So with the help of this display, we set the intensity of red light or infrared red light according to the given strength luminous that we get those luminous meter from the market, and the strength of the light which is required. We can set it with the help of 5%, 10%, 15%. Initially, we set it up. I'm sorry, I cannot show you the display at the moment. I'll make a video for that as well.
So basically, all parameters are controlled.
Yes. Sorry, it's taking. Sometimes the first demo is always the difficult one. The best part is that we all made it here in our own setting, and this is something new, and I think it's great. So then on the display, if you can see here, it's a display here. We have red light, infrared light, and time. So we set the intensity of all three parameters here on the display. I'll set the red light first so that everybody can see, because infrared we cannot see through the naked eye. I'm setting it till 30% of its full intensity. And set the timer of like 1 minute and set, and it starts. So what happens that it just gives us a wavelength of it gives light of specific wavelength. That is what is being taught internationally, that red light, what does it do? Low frequency red light stops the progression of myopia. It has certain magnets on the back of its display. ये slit lamp के ऊपर attach हो जाता है, and it's there for 3 minutes, morning and evening, or with a 4 hours gap. Initially, we started a study here in Jinnah that जो patients high myopia की तरफ जा रहे थे, हमने उनको enlist किया और उसको इनकी data collect करना शुरू किया. It's just a prototype. We can change it in different shapes, like goggles or like that, or there are different designs worldwide being used. So what's being taught that this helps in stopping the progression of myopia. Let's see that we have started our study on it, and it's doable, I think. So any question?
We'll take the question.
Okay. अभी तो we are doing it. We have read it और ये काम कर रहा था तो it will take a year or
Patients
so.
have reversal of myopia. That does not happen. But this is the only treatment where they found a subset of 10% of the patients it was reversal of myopia. How that happens, we don't know. What is the mechanism, we don't know. Now I'll be the devil's advocate. There are caveats. There are studies. 14-year-old boy used RLR for 5 months, and there was photoreceptor damage, clinically visible. So we don't know the efficacy, the long-term safety of this treatment. Yes, it works. Yes, it works good 50-60% of the times. Another catch-22 situation is there's rebound effect of this treatment. You put the patient on RLR, you stop the treatment, the patient goes back to somebody as much as the myopia starts catches up with the controls or the placebo ones. So it's just out there, something very new, but everybody's has they don't really give an opinion, but it is being dished out in clinical settings in across the board in China, in good academic tertiary care centers. Okay, the second thing is very much new. It is still being done, which is called the scleral cross-linkage. We all know what is corneal cross-linkage. They're experimenting right now. They don't have robust data even from animal models, but it is something that they're really looking at so that somehow they can just go in there. The problem with anterior posterior axial elongation of myopia is the access to the posterior bed of sclera. It is not clinically accessible. So that's another problem. But right now, I just put up these different combinations, but it's even not approved in animal models. The last thing is something very new: posterior scleral reinforcement. It's called PSR. This is done in a few Chinese academic centers. It's usually done by VR surgeons. They take up an implant, cut it in, remove the muscles, trying to slide it in behind the sclera, and then they look at the microvasculature of the choroid and the scleral thinning. They usually reserve it only for really high myopes, people more than 28 millimeters, more than 30 millimeters, and they're very young, 6-year-olds, 8 years olds. So the data is not there yet, but they have clinically started doing that, and it has good results. And the vasculature improves, the thickness improves, stuff like that. Okay. So across the board, over the last few decades, people are talking about myopia now. When somebody types in myopia, they get a lot of research titles now. All right, now from a clinical perspective, and this is probably what we'll discuss at the end of this talk, what to do when a patient comes. Usually, atropine is the first choice. All right, it's kicked off as 0.01%. We don't have evidence from our Pakistani population that whether 0.01% is going to work in us or not. If it's not, we switch to 0.02. If it's not, we can go up to 0.05. The current understanding is even in Asian population, sometimes the atropine just does not work. When it does not work, then we don't use atropine in combination therapies. So that's point number one. Second thing is atropine can always be added in. We put somebody on atropine. Now we cannot really increase the dosage because the kids are going to have complaints throughout the day. So what we can do is we can add in something. Maybe we can add in some ortho if he or she can afford it, or we can add in some defocus spectacles or some variant of defocus contact lenses based on their preference or their choice. So that's something. And there are people who are even talking about triple therapy. They kick off with atropine, add in ortho K, and with ortho K, the defocus cannot be added in. Why? Because the whole point of ortho K is the kid sees clearly throughout the day without any contact lenses or without spectacles. But with atropine and defocus lenses, clinicians have started using RLR to their patients when they still find the progression. The data on combination treatment is really low, and so that's the new videos. Okay. All right. So I've hinted over here at a couple of things. This is expensive. It costs about $200-300 just to get a device. Over there, we have devices which is like a handheld slit lamp. So we give it to the patient. It's quite user friendly, and as Irfan said, they can also modify this. How to give it to the kid. Posterior scleral reinforcement surgeries. These were expensive options. Ortho-K is also expensive, but defocus spectacles are slightly cheaper. The cheapest options are environmental exposure, sunlight time, the daytime, and atropine. It's really cheap. Maybe we should just discuss this with industry partners as well, so that they can just dish it out. Going to an OT and preparing it under sterile conditions, we can do that over here. But when we tell that to somebody living in a rural environment and some optician or optometrist over there, it becomes a challenge. Okay, now the cost effectiveness means we are doing these treatments and we want to see a benefit. For a traditional myope, would probably only use his glasses forever, and when he developed cataracts, just took them out and had cataract surgery. That's scenario one. We compare that with somebody who's developing myopia, and we offer all these atropine, ortho-Ks, defocus, RSRs, PSRs. Is it even worth it? Number one. Number two, how does this turn and translate into a public health perspective? What about that? Who is going to have these uncomfortable discussions and talks? When we take this data and we sit down with a policymaker, with a health expert, someone who can make policies on a national level, we need to give them robust evidence. Look, man, there is this cost of disease or burden. You do this, you implement this, and it's going to have this much effect. We don't have that on a national level. We need that. Okay. All right, so this is just a Cochrane database. I apologize for the blurriness of thanks. So what they did was they looked at all the different treatments, uncorrected single vision lens, methylxanthine, and RGP contact lenses, and pyrazipine, and low dose atropine, medium dose atropine, high dose atropine, and then they looked at the effect. All right, this is a Cochrane multivariate, multi-analysis, the most robust form of analysis. And what they really found was, at the end of the day, the evidence is not too substantial, and it's just about 0.2%, even for combination therapies. Can you scroll down a bit? So this is the axial length at year 1, and this is the axial length at year 2. And what they also found was, as time goes on, there is this plateau effect that the observers and researchers see. Can you go down a bit? Yeah, so I think that's it. Zoom out a bit. Zoom out, yeah. So these are the current guidelines. This is from an American Optometry Association. It is not nationally implemented even in America. We can use this and maybe apply it to pick it up. We know the earlier is picked up, we know the higher are the chances of its detrimental effects of myopia. The younger a child becomes myopic, the higher he or she will be, and the higher he or she will eventually have the associated complications. So these are just guidelines. It is not, I would repeat that, it is not nationally implemented. These are just guidelines from one of the associations. These are not American Academy of Ophthalmology's guidelines. This is American Optometry's guidelines. And you translate that to a place like Pakistan, and we would have back and forth discussions and fights and arguments. It's not feasible and practical. We don't even have that many ophthalmologists and optometrists and even qualified technicians. We don't even have that much awareness, even in our pediatricians, even in our pediatric doctors community. Most people don't screen kids. Most people just take vision for granted from a public perspective, from a clinician's perspective. So this is the last part of the talk, right? How we talked about what is myopia, we talked about it's a growing problem, we talked about onset and progression, we talked about some basic molecular mechanisms, how we can address that, and where we are in 2025 from an understanding point of view. And then we talked about the different options we have with all the caveats and the nuances. That's good. That's all academic stuff. What about practical? What we can do from tomorrow? This is a tertiary care environment. It's much easier to adopt or implement or dish out something in an academic institution. Uh, and when we want to replicate that to a rural area, to a basic health unit of Pakistan, to a rural health center of Pakistan, even basic stuff like vision screening, to a tertiary, what do you call that, THQ, Tehsil Headquarter Hospital of Pakistan. It's a tough thing to do. It's a tough discussion. So, and as our esteemed colleague mentioned in the beginning, what about the madrasa kids? What about the kids in the government public education sector? How we can tell and educate the parents? Pakistan is one of those countries where the youth is 40%. That means from day one to 20 years of age. That's almost half of the population. That's where myopia is. Myopia stabilizes. More than 90% of myopia stabilizes in third decade of life. Evidence is there. Yes, 5-10% do keep on progressing even in their 20s. But most myopia stabilizes towards the end of teenage years and definitely in third decade of life. And when we have such a massive population and there is no awareness from a public perspective, I'm not talking about from a clinician's perspective, from a public perspective, how can we address that? What are the barriers? What we can do from a clinician's perspective? There are people who take public health as a lifelong career. They're very few. They're even harder to come across in Pakistan. So I would like to end this at these uncomfortable notes that it's not just what I can implement from tomorrow to my patients. The problem is way more serious than that. And we need to have these discussions. We need to call industry partners and public health people and policymakers, and so that we can do that, and we can have some national policy maybe for our future generations. So that's about it. Yeah, I mentioned this previously. So for teleophthalmology and artificial intelligence, we need data sets. Right now, the data sets, yes, right now there are algorithms and they're already being publicly dished out, even in A&E and emergency departments in Europe and America, where the patient goes, sits in the machine, they take the picture, and they grade the diabetic retinopathy. That's robust. The clinician will not even look at the patient, and based on that, they will just take a decision. Oh, this is background NPDR. Okay, I'll see you after 1 year. Based on the decision of a machine. That's how robust over there it is. Why? Those guys kept taking pictures of diabetic retinopathy for decades, and they can train it. That's not the case with myopia. We are just starting to beginning to understand that. We need data. Once we have data, we can train the machines with deep learning and artificial intelligence and blockchain, and then maybe we can have the answers on a public, massive scale where it's just one machine. The guy puts in his eyes, and machine tells them, okay, fine, you need to have a proper comprehensive eye examination, or we can see you after 1 year. We'll be happy to take questions and anything like that. That's the end of the talk.
Any questions from the audience?
At what age we stop active payment, and if we tend to stop it at 18 years or 20 years of age,
then you will abruptly end it, or you need to taper it off? No, there is no concept of tapering. Then we need to abruptly end it at 18 or 20? Yes. It depends on how long. So I was over there, right, where this study was happened. This was Singapore National Eye Center. So the researchers, and they had kids for more than a decade on atropine, 0.01%, 0.02%. When they are sure, so over there, the clinical practice right now of a myopic kid is they come, take the history, take the physical examination, and they do optical biometry. They can even do optical biometry of as young a boy as kid as 2 years. I know it sounds unbelievable, but I would see that happen every day. So based on that, when they know that okay, fine, this kid is not growing, the eye is not elongating anymore. He stabilized at 26 millimeters. Good. Now we can have the discussion of stopping it. Sometimes they will stop it at 15. Most kids, most clinicians, the ones who were, they had a whole department of pediatric ophthalmology with 20 doctors. They would just stop it, towards the end of 18 to 20 years. And they don't, they do it abruptly. To answer your question specifically, there is no tapering concept. Even if somebody is on a 0.05%, they will not first go to 0.02 and then 0.01. They say, okay, fine, I think it's time to call it off. Good question, thank you.
What about the age? So does age matter? Like child is my work.
Yeah, so over. Yeah, exactly. So this is where the discussion with the patient comes in. Normally, the guidelines that we had over there is because most eyes, the emetropia age is about 9 to 12 years, 10 to 11 years. That's when the normal human eye becomes emetrope. But we do know that people who have early onset of myopia and they're progressing, even when they're 14 years old. I have a kid, he comes to me, he's 4 years old. He is -2. I do the exit length. He's about 24.5 millimeters. Every year he is growing. He is not on any treatment. He is growing half a diopter. 10 years down the road, he has from -2, now he is -7. So I would, every time that I would see that kid, I would have this discussion with that. Do you want me to put you on? We don't force it. The model that they practice over there is biopsychosocial model of health practice, where it's a shared decision making. I can put you on atropine, but you're going to be on it for next 10 years. Do you want that? You cannot miss the dose. There might be a chance that I have to up the dose. So once somebody agrees, sure. The compliance is a really big thing over here, from a clinician's perspective. I did not touch that on purpose because this is a really vast topic. I have to cover a lot of things. But compliance, not every patient will come back to you. You put somebody on atropine and they think, oh, it's like a magic drug. Oh, I'm not going to progress anymore. That's not the case. The success rate is 60%. Right? So, yeah. Good question.
I want is that rather I ask all my senior and communities that are we ready to do this? Exactly. Are we, the ophthalmologists, ready to spare our chair time for this purpose? Sure. I think that it is not going to happen. So let me put a possible solution. Rather than wasting our optometrists on every tasks which are they're just doing refraction. True. And all over the world, optometrists they are doing wonders. Just letting them know their place, doing their ethical training and giving them this. Even we can start a myopia certification for the optometrists. True. And put this burden of this surveillance, this monitoring, and even reporting this data by the optometrists. And let me tell you something: the state of the optometrists at this place. Optometrists बेचारे जो हैं उनकी इस वक्त कोई central organization ही नहीं है. We need to work on that. ये हम लोग नहीं कर सकेंगे. Let me be very frank. We are busy in our cataract surgery, refractive surgery, retinal surgery. We are not going to do that. अपने बच्चों को नहीं कर पाएंगे. नहीं कर सकते. मेरा ये एक छोटा सा आइडिया हमेशा से रहता है कि let us attach one optometrist in every private clinic. In every private clinic, teach them. मेरे साथ optometrist उसने myopia control certification दी है. I have started a separate market control clinic, and he's doing all this stuff. Obviously, I'm with him. We do optical biometries. He does dynamic diagnostics. He does the dual diameters. He does everything, the accommodation lag, and he documents it. लेकिन ये चीज अगर एक ट्रस्टी के सेंटर के अंदर जो है अच्छी डॉक्यूमेंटेशन के साथ जैसे मेरे कलीग डॉक्टर इरफान ने कहा कि ये स्टार्ट हो जाए और दिस शुड बी लेड बाय द ऑप्टोमेट्रिस्ट उनको भी जरा लगेगा कि
They're empowered. Yeah.
दे विल डू समथिंग उनको हमेशा ये फील होता है कि हम लोग पीछे हैं और डॉक्टर्स को ये फील होता है कि हमने उनको थोड़ा सा आगे कर दिया तो वो डॉक्टर जो है ना वो मैं मेरे जिम्मे में ये बात हमेशा आती है कि बहुत बड़ी वर्क फोर्स है बहुत बड़ी वर्क फोर्स है इसमें से जो अच्छे वाले हैं उनको स्क्रीन करके जो काम की कर सकते हैं उनको हम लोग ट्रेन करें हमारा काम ये होना चाहिए देखिए हमें एक लेक्चर से बहुत सारी चीजें समझ आती हैं ठीक है ना लेकिन ये काम करना ये बच्चे कर सकते हैं ये लड़कियां ये लड़के ये यंग भी हैं इसके अंदर एक पूरा पैशन भी है हम भी 40-45 साल तक पहुंचे हुए हैं ना ये शेयर टाइम हमसे भी किया आई एम सॉरी आई माइट बी ब्लंट लेकिन दिस इज व्हाट आई
Sure. Good.
Again, optometrists, maybe we are as an optometrist in our hospital already prescribing 0.01% atropine to our patients.
Wow.
At that dynamic impact retrospective.
Wow.
And we do conduct a study almost 4 months before. That was a comparison between 0.01% atropine versus placebo.
That's too soon. It's too soon.
Study for 6 months that didn't get such a vast person. So my question is this: how long we can decide that we can shift to some other concentration of atropine to a particular patient? Like I prescribe for 0.01% to a patient. How long I have to wait for that concentration to respond from that particular patient, or I have to decide that I will shift to moderate atropine concentration like 0.5% or 0.2%?
Yeah. So we call our patient back in 3 to 4 months. Let's say I have this discussion with the patient that okay, you are progressing, man. Do you want me to put you on something? Are you interested in some form of defocus glasses? Do you think you can afford that? Once the decision has been made, okay, fine, doctor, let's kick off the atropine. I will start off with 0.01%. Now I will call that patient back into the clinic about 3 to 4 months, right? And I would look at the refractive error. If I see it's stable, I will not do optical biometry. If it is not, if there is a growth, right, then I might do optical biometry on that visit. Otherwise, I would do it on twice a year, stuff like that. So it's like a nuanced thing. Patient to patient, it varies. Clinical age matters. The burden of the cost of these tests. OCT is not cheap in Pakistan, and so these things matter. But ideally speaking, in an ideal environment, every time a patient comes, even before he or she sees me, when I'm sitting down, doing the clinical decision with the patient, I want the biometry on the screen. That's a utopian world. Yeah. जी कॉस्ट इफेक्टिवनेस के साथ एप्लीकेशन का आसान तरीका ये है कि वी गेट स्टैटिस्टिशियंस people who have done this in the past with other treatment modalities and interventions, and we work with them. Without robust public health statistics researchers, we cannot come up with a cost-effective model to present to any authority कि भाई हमें ये करने की ज़रूरत है. That's number one. Number two, right now atropine is not available commercially. And preparing it in an aesthetic, aseptic environment, that in itself is costs, glove costs, going to the OT costs, the putting on a aseptic gown costs. There are these little teeny tiny costs. When we multiply that on a national level, the cost is too much. Every time we scrub in, there is a cost. Somebody is bearing that cost. If it's a private setup, if it's a trust care hospital, if it's a public setup, every time we do anything under aseptic measures, there is a cost. And on top of that, there is a cost of that atropine drop itself. There is a cost of that atropine injection itself. So we need to have this versus, ठीक है ना, आधा डायopter progress कर रहा था, बस ठीक है, rebound का भी है, we were scared that the kid might not follow up, right? So the take-home message from this talk is not that every kid should be on atropine. The take-home message from this talk is there are options. We need to be aware of this. It's a growing prevalence. What we really can, which doesn't cost anything, that's the onset. The kid never develops myopia. That's cheap. Just spend time outdoors. Just have a normal, healthy lifestyle. I hope I answered your question.
Record one important
जी
अपने एनवायरमेंट की बात करें इसी तरह से जो पेरेंट्स हैं
ट्रू
ऐसा टोटली न्यू सॉर्ट ऑफ थिंग नहीं है
एक बिल्कुल नई चीज है
दैट इज अ ह्यूज सॉर्ट ऑफ एजुकेशन
100% agree 100% agree and most of the times it's a 3-year-old boy. The boy is not going to listen to me, or even he or she is not going to listen even to his parent. Why? The boy is already addicted to his screen. अब जनाब अली वो डंडा लेके अगले दिन अम्मा जो है ना चल बेटा चल बाहर सूरज में चल डॉक्टर ने कहा तो अबदाना हो जाए. That causes problems. The mother is overworried and the father is anxious. So there are all these psychosocial factors that come into play when we have these uncomfortable conversations. So yeah, I totally agree with you.
It's not simple.
It's not simple. It's not just 0.01%. I go to I put it and I take a 0.1% of atropine, dish it out, and okay, bye bye. No, it's everything. It's the whole picture. If we miss that out, and then I think I did not do a good job. So it's whole. Thank you for bringing that out. It's the whole thing.
Probably we are just in the beginning.
This is absolutely very humble beginnings. It is very much beginnings. It is very much beginnings. We probably need this something like this every महीने यार वो myopia के लिए खड़ा हो जाता है. We probably need this reminder again and again. And the real reason why I agreed to this with Irfan was our graduates, was our future doctors. I want my grandkid or my kids to be in a comfortable environment where they get the best possible care by being in Pakistan. So that's what I want. I want them to go out and do the best and come back and start some research centers. And we can do this. We have the data. We have the resources. We just don't have the, I don't know how to put it. We lack that. We lack that drive to find out these answers ourselves. Otherwise, we can do it all. I strongly believe that.
Thank you so much for a very detailed talk.
Sure.
My question is, I am from involved with a few glasses prescription from Scandinavian
Right.
Norway, and they are describing progressive glasses in Gen Y.
Right.
Do you have any experience, and what is the logic behind it?
It's the same thing that the first. Yeah.
Yes, it relaxes in the combination. And
Yes.
So it's a very simple thing.
Yeah.
We should also apply these same practices, and in this way we can it's more cheaper, I think.
So the point is, yeah. Exactly. No, the reason they came up with these ones is because compared to a progressive glass, spectacle glass, where it's just a vertical thing, they switched to the progressive contact lens. So the 360 retina is affected like that. So it's slightly better than this vertical meridian type of glass. So that's what they did in the Blink study. That's what they did in those studies. Yeah. So, but again, even progressives are not cheap in Pakistan. It costs like 10,000-20,000.
It's more cheaper than defocus.
It's definitely more cheaper than defocus. It's definitely more cheaper than
My second
defocus.
question is, what is the success rate of low dose exposure of red light, and what are the
It's about
LR?
Yeah, it's about 60 to 70%.
What are the most worst complications?
There's just one case report, and the researchers from China, they reported it right away. They put on a 14-year-old young kid, and after 5 months, they found photoreceptor damage, clinically, obvious. So that's what I was like, oh, hold on, man, there's something is off about this. So what they did was they took the bench models from the companies that are dishing it out. They tested those bench models, and then what they found was if you go slightly more than 3 minutes, the luminance, the energy, the wattage, all of that, the parameters are totally off. So it has to be really controlled. Now replicate that to a person who cannot even write his name. That's us Pakistanis, right? Most our patients are like that. Or yaar ye to light laga le, badi sasti hai, 2,000 rupees ki aati hai. Let's say we'll come up with a democratized version. Do you really expect? We are the kind of people like, अच्छा light से कम होगा, मैं पूरा ही zero करता हूँ, ठीक है ना? So we are those kind of people, ठीक है? एक समोसा नहीं 10 समोसे चाहिए. So we give a sensitive device to a layman, and we expect them to behave like a research subject of a world-renowned study. That's exactly what he's saying. This is easier said than done. This is just we need to have these uncomfortable conversations. This is easier said than done.
Why not promote outdoor games?
Exactly, I'm totally up for that. That's what I tell most of my patients. Please, it will not cost any money. It will affect your child's mental well-being. Okay, there are concepts of mental health now. I hope there is a concept of eye health now as well in Pakistan. There are concepts of mental health. Just spend time outdoors, make him play, buy him a bicycle. I don't know, he wants to play cricket, whatever he wants to play. Go out, be physical. Don't do swimming on a video game. Go out and do actual swimming and actual running. And running is the cheapest way of having any outdoor healthy activity, or even strolling or jogging or walking for that matter.
Thank you, Dr. Ahmad. You have given a very elaborate talk. और मैं सोच रहा हूँ, हैरान हूँ कि दुनिया क्या से क्या हो जाएगी.
Bishop, no doubt.
My desire would be nobody should need glasses. Nobody should be myopic.
I totally agree with that.
With the research, the effort you people are putting in, question is, would it be possible?
Yes, there is. I'll answer your question in a flip way. We were attending this discussion the other day about myopia complications, right? And somebody asked this question. Okay, you guys say by 2050, half of the world will be myopic. So answer this question: by 2100, will the whole world be myopic? Has humanity lost this natural gift that it had forever? Right? So, and then there are people said, no, this is a new problem for us. We can tackle it. Okay? We don't understand the genetic play the way we should. People are talking about fetal mortality. We come into the concept of, euthanasia and all of that. The discussion would just delve into that. But people are talking about attacking and addressing at the genetic level. There is a huge gene environment interplay in the pathogenesis of myopia. Will we be able to do that? And will we be able to answer all of those questions with certainty? Only time will tell. But that's the dream. My dream is one day there is no ophthalmologist in this world. That's my dream. That's a humble man's dream, right? Well, the machines can just cure it and fix it all.
But the second question is more really
Yes.
It has always been there,
Yes.
but it was not diagnosed.
To an extent, yeah.
If you look into the medieval time,
Yeah.
Muslim scholars writing books at the age of 60.
True.
Were they not presbyophic? If they were presbyophic, or they were writing it, there were no glasses.
Yeah.
It means at the same time they were myopic as well.
True.
My family, half of them are myopic.
Right.
I was kicked out of the school hockey team.
Because you're myopic.
When I was in school.
इसकी चश्मे में हॉकी ना लग जाए.
My education as madam, we are only 9 miles. She is from Goja and I am from a village nearby. And in those days, 60 years ago, hockey was a craze in our area.
Yeah, true.
And Goja was the center of hockey nursery.
Wow.
And we all studied there and we all played hockey as much as we can. My brother was captain of the hockey team and he picked me out. And I was he said, you are playing for the opponent. You are missing the ball all the time. Because I could not see it clearly. And I was checked by the local doctor and told the guy you need.
Oh my God.
Myopic.
This is true story. Wow.
So, it was not that it is increasing. I believe that we are discovering it more.
There is an element of that as well, especially in a country like Pakistan.
In olden times, it used to be a phrase that a person who wears glasses is more intelligent than others because he could not play the hockey team. So he had to sit in the books.
There are studies that say people with higher levels of education have more myopia. Does that even cause it? Higher education. It just boils down to the same basic pathophysiologic mechanism. People who study, they don't go out, they don't play, they don't have a healthy lifestyle. Maybe they do more time near work and spend time indoors. Maybe that's why. But there are studies that categorically point that out.
My senior colleague, late Dr. Dilbon Mirza, told me the story. He said, I was examining my father's eye and I found that, he said, oh, I have no problem. I can read a bit of it and I can see distance, all right. What he could see distance outside was 6 by 1,000. You wanted to see his cow in the field. And he could see that, but it was heavy.
It's not a counting finger, it's a cow finger.
And he could read the names. He could see his grandson running around. So, am my grandson. So I used to usually write it down like that. And then he said, when I looked at his eyes and reflected him, he was minus 2.5. And I gave him the glasses of minus 2.5, and it was far away. And he said, he gave him the little school. And he said, why I have made you a doctor? You never checked my eyes before. I have written all this word all my life. So, myopia has been there all along.
True.
And it's only that we are now finding it. Look, glasses is to be on the right side. If you read it all, there are all these opticians, dispensing opticians, and old people like me would go away, whose earning is probably refraction. Come on, man. And finally, at my age, or 70 plus, can I have my myopia reversed?
Okay.
Thank you very much.
Thank you.
I wanted to ask one question. I observed a patient. He said that he made those classes from England and he's one of myopia lenses. But he said it costs around 5 lakhs. So I wanted to know, do we have any options locally?
Yes, we do.
Which are like
Yes, we do. I'm not here to promote anybody, right? And I don't have any personal financial interest with anybody whatsoever. If I did, I would have disclosed those financial interests at the beginning of this talk. But from a clinician's perspective, डॉक्टर साहब आपने FFA लिख दिया कहाँ से कराएंगे डॉक्टर साहब आपने स्वेप सोर्स लिख के दिया कहाँ से करवाएंगे इट इज माय जॉब टू टेल देम कि अच्छा जी यहाँ से ये हो सकता है सो व्हेन आई टेल समबडी कि ओके फाइन go get defocus classes. It's cheap. It's it's relatively cheap, and you're the type of guy who can afford it, and it works. कहाँ से लूँ मैं? So it is my job to find out where are these people. So there are some couple of people in defense and everything. His optom also is doing that. He imports it from Italy as well. Dr. Rash's optom. So there are people, and it's just again one of those things. You and I are clinicians. We look at a problem differently. We were discussing this the other day with Dr. Andali. When a businessman looks at a problem, he looks at it differently. He says, oh, I can make money from here. When all these brands and chains and everything, when they find out there's so much myopia and they're realizing that, right now they're just selling them 10,000, 20,000 glasses, right? When they find out, oh, we can make 10,000 more, or we can make 20,000 more, they are going to import way cheaper versions of defocus glasses. Right, so it's not that expensive. The cost that I found for them, because my nephew is myope and he's only 3.5 years old, and so it was like 50,000-60,000. It's a guy in defense here.
Assalamu alaikum. I'm an ophthalmologist by profession and I'm a medical department at the University of Lahore. Thanks a lot for giving such a wonderful actually, I want to just give a little bit suggestion because it's a great platform. All of the optometrists, ophthalmologists, stakeholders are here. Actually, the scene is that we are quite different from other countries.
Agreed.
We have a culture, different culture.
Agreed.
I think we know the monster is coming. Yeah. But I think we need to give awareness to the parents, to the community. That's the first priority we have to give. So on that platform, I want to suggest that can we plan a national strategic plan for myopia
That's exactly what that's what I briefly touched at the end of the talk.
We cover the awareness.
Yeah.
We cover because we don't have any research and development R&D.
No, there's no.
And the main part of the optometrist in right now in this is orthokeratology, and we have no orthokeratology in Pakistan right now.
It's very expensive.
Yeah, it's
very
expensive, but
expensive.
we don't have a trainer right now.
Yeah, true.
We and if you go for the contact lenses, we have limited number of practitioners. So we have both ophthalmologists and optometrists can combine, make a national strategy plan, and which will cover the awareness because WC, World Council of Optometry, has already given the steps, awareness, mitigation, and everything.
True.
So we can just implement it here, and I think it will be a better option. Thank you.
Yeah.
Thank you very much, Dr. Nabeel. I think this was one of the best talk, and this was basically a comeback from the Jinnah Hospital, Lahore, and Dr. Professor Ahmad Sahib will brief what I mean by that.